All right. Looks like it's just a little after 8 a.m., and we are so excited to have everyone here. Good morning. I'm Katie Butterfield, the Director of Quality System and Improvement for the state of Oklahoma and the Heart Failure Lead for the 6th state affiliate. I'm joined by Sherry Boxberger. I just called Sherry. Her name is Sherry, the Regional VP for Heart Failure and Resuscitation for the affiliate. Welcome to the second installment of the Heart Failure Quality Exchange. This is a quarterly phone call to allow hospital teams who are working diligently to improve care for our heart failure patients. We come together, learn, share, and identify resource needs. I hope you'll invite your colleagues to join us for these calls. Everyone that is passionate about heart failure is welcome on this call. We're also holding quality exchange calls for resuscitation, atrial fibrillation, stroke, and coronary artery disease. So those of you who pre-registered should have received some slides that serve as a foundation for our meeting today. If you did not receive this email or the slides, please just send an email to Larissa DeLuna. Her email is Larissa, Larissa .deluna, DELUNA @heart.org, and she will send those slides to you. Everyone has been placed on mute, so if you would like to join the conversation, which this is a very informal call, please just press *6, and that will unmute your line. To mute the line back, please press *6. We want this to be interactive. Please don't hesitate to unmute, speak up whenever you have a question or a comment. The topics for today's call, we have some really exciting ones. An introduction to the Cardiovascular Center of Excellence, which is including the heart failure pillar. We're going to speak a little bit about the Heart Failure Society of America highlights, which was just recently held in Grapevine, Texas. A look at the performance by our affiliate, our 6 states. 2 hospitals are going to share best practices for heart failure management and group discussion. And then the demonstration of our brand new resources. So let's get started. Here's some things that are new. So we are actually going to ask Joyce Wright, who is part of our American Heart family. She's going to jump in and kind of give an overview and what's new and how the heart failure is a pillar of our Cardiovascular Center of Excellence. So Joyce, if you would like to press *6, come off and give us your overview.
Thanks, Katie. Cherie and Katie asked me to speak to you today about the Cardiovascular Center of Excellence accreditation. This accreditation is a collaboration between the American Heart Association and the American College of Cardiology. And as you know, we are the 2 leaders in cardiac care. The original requirements for the Cardiovascular Center of Excellence, and you're going to hear me say CVCOE, that is the Cardiovascular Center of Excellence. So the original requirements for CVCOE were that a hospital needed to have 3 ACC cornerstones and then apply for the Cardiovascular Center of Excellence. We found that there were many hospitals that had stellar cardiac programs, but not necessarily the 3 cornerstones in place. So we developed a limited time offering for early adopters. So this offering is available through January 1st, 2018, and it does not require you to have the cornerstones in place at this time. The hospitals can become CVCOE accredited and then go back and put their cornerstones in place. So let's quickly talk about the cornerstones. They are administered by the American College of Cardiology. So the marketing you will see, even though this is a co-branded product, but on the cornerstones, the marketing that you will see is ACC/AJ. There is one mandatory cornerstone, and that is the Chest Pain Center module. And then you will need to choose between 2 of the following 3, heart failure, AFib, or cath lab. And anyone who is doing Get With the Guidelines CAD, Get With the Guidelines heart failure, or AFib, this is a great tool because there is a free layer that you can add to the Get With the Guidelines tool that can be turned on in quintiles and will meet the data requirements that ACC requires for their data registry. The AHA IT department has gotten the data elements from ACC, and they have matched them to the Get With the Guideline measures. The items that are not included in the Get With the Guideline, heart failure or AFib or CAD, are put into a layer so that you can just turn that on and you will meet the data requirements for ACC. So let's talk about the capstone. Well, you'll hear capstone or CVCOE. Those are the same thing. This is a portion of the accreditation that is administered by the American Heart Association. So the marketing that you will see will be AHA/ACC. And this is a cardiac service line accreditation that looks at systems of care, starting for when the patient is picked up by EMS, brought to the hospitals, entire way through the hospital, out into the community, back into their home or cardiac rehab or nursing home, and then on to preventative medicine. So the benefits of this accreditation include making the hospital as a driver of change for health in their community to improve health. Public recognizes the hospital for their commitment to high-quality care. The accreditation provides standardized, cohesive, consistent, multidisciplinary care. The quality improvement data from the measures from the data that we collect allow the hospitals to identify disparities and gaps in care and implement quality improvement programs. It's a great recruitment tool for physicians and other healthcare staff. It allows patients and families increased participation in their care decisions. And this is really the cornerstone here for us, is how to make the patient care better and how to make outcomes better for patients and to improve their quality of life or allow them to have the best quality of life possible. This accreditation also ensures that multidisciplinary teams are talking with the patients, again, to coordinate care. It provides education out in the community so that patients have early access to care. It shows dedication to quality of care close to home, and we also look at patient safety. So let's just look at maybe one of your heart failure patients. It will be a comfort to know that if they came in for heart failure and ended up needing a valve replacement, that all those systems in your hospital were communicating and making decisions that were in the best interest of the patient. And it would follow them through the entire hospital stay. The requirements for the CVCOE are those three cornerstones, but we are not going to be looking at those cornerstones again. Now, ACC has already helped your facility achieve those cornerstones, so we are going to be looking at other things like the entire cardiac service line, like your cardiac surgery areas or the lab or the echo people or cardiac rehab. I already said that, but looking at the entire cardiac service line, not just individual disease states. Okay, so we want to make sure that your patients are getting timely information about their disease state and making sure they understand and are making the best decisions for their care. Now, let me talk about the early adopter limited time offering just a little bit more. We really want to meet you where you're at and help you meet your goals. So the early adopter limited time offering is you do not have to have your the three cornerstones in place. But we will be sending you a readiness assessment. The readiness assessment will just take a look at what systems you already have in place in your facility that might be equivalent to what needs to be there for CVCOE. So there is a cost for the readiness assessment. It is $9,000. And let me just back up just a minute. The cost for the CVCOE during the limited time offering is $57,000 for a 3-year accreditation. So that's $19,000 a year, and we bill it annually, $19,000. Now the first year is just a little bit different because of the Readiness Assessment. The Readiness Assessment is $9,000 to cover the fees for that. So you would first what you would do is submit your application, get your PHA, your participating hospital agreement completed and signed, and then submit your Readiness Assessment. We'll invoice you for the $9,000. And then there's a committee at AHA that will take a look at your Readiness Assessment. And once they make a decision as to whether you would be able to sustain a CVCOE, we'll let you know, and let's do the positive first here. You are approved to move forward. So what you would do is move on to the desk survey. And the desk survey looks at all your supporting documentation that supports the CVCOE standards in the standards manual. We have a reviewer that you'd be working with, and you would submit things like your charter or your policies and procedures, and we would take a look at that to make sure that the documentation is what we're looking for. Once that process is completed, and that generally takes maybe around 2 months, so once that is completed, you move on to your on-site survey, and that is where the reviewer comes to your facility, and the purpose of that is we have seen on paper what your facility does, but we come to see it in person to make sure that everything on paper is what's actually happening in the facility. So let's move to the the negative here. If your hospital, if the committee decides that you are not ready to move on to the desk survey, then the reviewer will give you some recommendations to help you with an action plan to put things into place to get yourself ready. You will not get your $9,000 back. However, you can apply again. You have 1 year from the date your participating hospital agreement was signed to reapply and submit your readiness assessment a second time or third time to get ready for CVCOE. And at that time, when the committee feels you do have those systems in place, then we'll move on with the desk survey and the on-site survey. I know that was really quick. I know there are other people that need to talk, but are there any questions that you have about CVCOE?
Yes, if anyone has a question, please hit *6, and you will come off mute, and you can ask Joyce a question. And if you think of something or maybe want something more specific about your hospital that you'd rather do in private, you can always contact Cherie or I or Larissa with your question, and we will make sure we connect you with Joyce.
I'd be happy to help you out. Just feel free to contact us.
Joyce, thank you so much. It's really good information, and hopefully we'll have some questions come in through email that we can connect you.
Okay, thank you.
Thank you so much. Okay, moving on, Cherie Boxberger is going to hop on and give us a little overview about using the CSV uploader for heart failure, which is very exciting. This means you don't have to hand enter everything, which I feel like is something we all want to hear. So, Cherie, if you want to come off mute and give us a little information about the CSV uploader.
Yes. Good morning, everyone. Glad to be joining you. We did have around 25 of you pre-register for today. Just as a reminder, if you didn't pre-register, and I'm going to have some slides I'm going to go over, please pop an email to Larissa DeLuna, LARISSA.DELUNA @heart.org, and she'll get those sent out to you. Yes, CSV Uploader. Well, first, let me say this opportunity to be a cardiovascular center of excellence I believe in all of our states there's the opportunity for someone to be the first hospital to be able to promote themselves as a cardiovascular center of excellence. You know what that would mean, along with the AHA, ACC icons, to be able to demonstrate to your community your overall commitment to heart care. So if this is the first you've heard about Cardiovascular Center of Excellence, please reach out to your AHA director or pass the word along to your service line director or COO, CNO. It is a great opportunity. And I know there are a number of communities who are working diligently to see if they can be the first. So let's talk about the CSV uploaders. Many of you, as I look at the pre-registration list, have been a Get With the Guidelines heart failure participant for a long time. There are some of you who use an uploader because of your organization. For instance, Tenet uses Quantros, and so Quantros uploads the data into Get With the Guidelines. But even if you don't have one of those, all of you are eligible to have some of your data come directly out of your electronic medical record and populate into your Get With the Guidelines heart failure. I think sometimes we lose sight of this, that this is available. Even if the uploader only brought in date of birth, all of the date and time fields, you would still have significant savings. So I encourage you to reach out to your director. If you're not sure who that is, just pop an email to SWA, which stands for the Southwest Affiliate, SWA-quality@heart.org, and let us know you're interested in looking at the CSV uploader. This is available for almost all of our tools, and so I encourage you to see if you can save some time and effort by getting data directly imported in to Get With the Guidelines heart failure, and then you would just finish it out. Any questions, or does anyone use the CSV uploader who'd like to make a comment? Just *6. All right. Well, it is a, go ahead. Yes.
Sorry, could you repeat the email address that you said to send? We're looking to do this already, but we may need some help with some more of the specs just to make sure that we're right on track. Perfect.
Yes, just send it to SWA, kind of like Southwest Airlines, except in this instance it's Southwest Affiliate, SWA-quality@heart.org.
Thank you.
And let us know, and we'll be glad to give you a hand and make sure you have the latest specifications. All righty. I'm just going to give a few highlights about the Heart Failure Society of America. Hopefully some of you attended, and you can feel free to jump in and let us know what you learned as well. But Katie and I were able to attend the conference in Grapevine, Texas in September. And so I'll just share a few things that I learned in some of the sessions. Kind of just a foundational update. With 1 million hospitalizations per year, which kind of struck me that with heart failure we have 1 million hospitalizations per year in this country. But the proportion of those that are HEF is increasing. Right now it looks like across the country a length of stay to 4 to 5 days. The in-hospital mortality across the country is 3%. However, as you get to 60 to 90 days, it increases to 90%. And right now an average 30% readmission rate. And of course, if you go out to 6 months, it's 50%. Certainly, this continues to be a large and growing financial burden. I was able to attend a meeting where Dr. Fonro presented, and Dr. Fonro is out of California, and he is one of our physician leads on the clinical team that leads Get With the Guidelines heart failure. And he gave a presentation kind of reminding us what the goals are for treatment during a heart failure admission. Certainly, we all know alleviate symptoms. That's the reason they're coming in there initially. To reduce the extracellular fluid volume or congestion. Of course, that's one of the symptoms oftentimes. To improve their hemodynamics, because we really want the left and the right ventricles to have less pressure so they can fill more easily. Obviously, we need to maintain renal function so that all the organs can work well. And then we want to optimize the initiation and dosing of GDMT. I don't know if you've heard these letters before, but Dr. Fonro is using these pretty extensively. It's guideline-directed medical therapy. And so that is really what we're doing in Get With the Guidelines Heart Failure, guideline-directed medical therapy. So during the hospitalization, we want to optimize that kind of therapy that will improve the long-term outcomes. So kind of interesting looking foundationally what we're trying to do while they're there in the hospital. I also attended a session which was a study of 1,000 couples where one spouse had heart failure, and they actually studied the health of the caregiver to see if the non-heart failure spouse, how healthy they are, impacted the outcomes for the heart failure patient. And in fact, they found that it did not impact the outcome for the heart failure patient. But a learning that they did determine was that the death of the heart failure patient greatly affected the health of the surviving spouse. And so that suggested really a need for enhanced bereavement care. And when we talk about systems of care or cardiovascular centers of excellence, we can't forget that other end of the spectrum where the patient does die and how does it impact their family. And then one last study that I'll tell you about was about, well, actually there's two, adherence with post-discharge appointments. I would be interested in seeing how well your patients are showing up for the appointments you make for them. And so I think we all make a lot of assumptions about why patients don't show up. I know we've visited some federally qualified health centers, and they have quite a few no-shows, and they're trying to figure out why that is. But in this study, they determined what does not impact adherence. So it's interesting. The following did not impact adherence: older age, female gender, a lower socioeconomic status, smoking history, and this is interesting, distance to the provider did not impact adherence, as well as the number of heart failure medications. So those were not statistically significant for patients who did not follow up. Obviously, it's one of those deals where the research is indicating we need more research, but I think those are some of the things that I might have thought were related. And then finally, the last thing, and we went to many, many sessions, but something that was incredibly shocking was the disparity in the number of women who are evaluated and treated with LVAD and transplant. The data suggests that women are entering the system either so late that they can't have these things, or that practitioners, the primary practitioners, are not referring them early enough. There was great discussion related to women and them ignoring symptoms or them being worried about more things with their family and therefore not taking care of getting into the physician. But it is important to note that right now the LVAD and transplant rates are far lower than our male counterparts. And so these are areas that we need to be focusing on and figuring out how these women who are failing, whose cardiovascular systems are failing, can get plugged into the system much earlier and take advantage of the treatment modalities that are there. Is anyone on the line attended HFSA and would like to share something that they took away? Star 6. In a future call, we'll talk a little more about the use of social media with heart failure. Katie attended a very interesting session, but we don't have time today, but how they're using Facebook Live and some other elements to communicate with their patients and families. And so we'll put that on the agenda for a future quality exchange. You might want to just pop September 15th to 18th on your calendar. That is when the next Heart Failure Society of America will be held in 2018, and it will be in Nashville. Now, recently, and some of you may be on the phone who participated in a pilot program we did in Austin, we had heart failure providers, a full contingency, everything from dietitian to social work to physician to nurse, come together last week in Austin to talk about the needs of heart failure coordinators in that community. Katie, can you give us an update?
Yes, thank you. So like Cherie said, some of you on the phone might have been at this breakfast, and please jump in at any time and give anything that you felt was beneficial or things you'd like to see in the future, because I thought it was amazing. I am not from Texas. I actually cover part of Texas, but all of Oklahoma, and I live in Oklahoma, so it was really great to get into another market and see what's happening. We just simply met for breakfast one morning, brought some food in. We had a great attendance. I think 22 people came from only 2 or 3 hospitals. We had a physician show up. We had people, representatives from social services, representatives from cardiac rehab, heart failure nurses, quality, a really great spectrum of people who were passionate about heart failure in Austin. And we just did a small presentation about the data that we saw and Get With the Guidelines as a market in Austin. That was a small portion of the discussion. But the main portion of discussion was best practice sharing and barriers that we were seeing with heart failure, which was really great to hear different perspectives from different hospitals. Things like in Austin, they have a program called the MAP program for the uninsured, low income. I know that's only specific to Austin, but I know other areas have other programs like that where they're helping with health insurance and helping with the underserved, but it's also a barrier in getting them treatment afterwards and giving follow-up to them. So just some barriers like that we talked about. We talked about barriers to technology for these patients that one hospital was actually the social services. They checked in every week for the first 180 days post-discharge. Those patients were given a tablet, which we would love that hospital to do a presentation for us maybe on our next heart failure call, but those patients were given a tablet to keep track of their weight, their diet, how they're feeling, and social services would kind of check in with them every week, make sure that's happening. Then we discussed, had a little break, then we came back and discussed, is their data reflective of what they think they're doing? Do we want to do something like this again? We feel like that heart failure coordinators and people who are passionate about heart failure don't have quite the opportunity that people that maybe work in stroke or maybe work in STEMI don't have the same opportunity to get together and have something like that just in their region. So we are looking to do other pilot breakfasts or breakfasts in other regions of our affiliates. So obviously, if it's something that you all are interested in or think it would be a great idea for your area, we would love to host it. So, lastly, I will say that at the very end, we kind of talked about some different guidelines and different resources that we also offer with our heart failure program, and I'll go over that in just a little bit, but because that was kind of a big section that we discussed in this. But we did it together as a group where we signed on to our new resources, kind of went over them together, how they can utilize them for their patients, how they can utilize them as a group for their physicians and other clinicians. So that's something that was really useful to them. So that's something I'll kind of go over in a little bit on the resources section. But Cherie, or Stephanie, I believe Stephanie might be on the line too. If there's anything that you guys can think of that we also did at that Austin breakfast that you want me to elaborate on, please. Or anyone that was at the Austin breakfast, please feel free to jump on and say what you liked, what you would like to see added, or what you wish you could have had at that breakfast. I would love that. *6 to unmute.
Thanks, Katie. We're going to be reaching out and having some other opportunities for us to meet in person, even though we're really going to focus on data on this call. I did email out to those of you who pre-registered a slide presentation, and that's what I'm going to talk about now. So if you want to pull that up, it was called Heart Failure Quality Exchange 1030. So it came out with your reminder email. If you didn't get this, we'll make sure it's in the resource kit that goes to all participants. But we wanted to talk a little bit about our performance as it relates to the affiliate. For those of you who have the slides, slide 3 kind of shows the mortality rate for heart failure over the years. And for those of you who don't, I'll describe it to you. From 2005 all the way to 2012 or 13, the mortality rate for heart failure has gone down. However, starting in 2012, we started to see that mortality rate eke up. And so I included a slide that has that. And interestingly, I mean, we really believe that this is happening because we're doing so well on our time-critical cardiovascular diagnoses, so our strokes and our STEMIs and our NSTEMIs, that we do have many more patients who are surviving those and as a result may have heart failure and might have be more ill than in the past where they might have died from those things. So it's kind of interesting, but we definitely need to keep our finger on the pulse of the fact that the mortality rate in heart failure is starting to eke back up. Certainly not what it was back in 2005, but it is kind of heading in that direction. You'll see on those slides, slide 5 talks about the performance in the country as it relates to Get With The Guidelines and how by using Get With The Guidelines heart failure on slides 5, 6, and 7, you definitely improve your performance on the guideline-based care. But what I did want to share today is our performance, and when I say our 6-state performance, and for those who have the slides, it's slide 8. So the Southwest affiliate includes Arkansas, Colorado, Oklahoma, New Mexico, Texas, and then Wyoming, which sometimes people are like Southwest, but yes, Wyoming. And so as we look at the 4 key achievement measures, the first one, ACE-ARB-ARNI, we're performing just slightly lower than the country in that measure. We are also, while still high, near 90%, performing a tad bit lower on the evidence-based beta blockers, very high and very close to national on the LV function, although slightly below national. And then in the area of the post-discharge appointment, we've made great strides. We're coming in just under 70%, where in the nation they're coming in just under 80%. So in the achievement measures, except for that post-discharge appointment, we're less than the nation. Slide 9 takes up the next 4 quality measures of aldosterone antagonist at discharge, anticoagulation for certain patients, DVT prophylaxis, and of course, diagnosing, working and placing, evaluating and placing CRT therapy. So in all of these areas except for DVT, well, that's not true. Aldosterone antagonists, we're about even with the country, and we're all low at 40%. But in the other areas, performing lower with anticoagulation and the CRT than in the nation. The final 4 quality measures, ICD evaluation and or placement, influenza vaccine, pneumococcal vaccine, and then the follow-up in 7 days, we exceed the performance of the country on the influenza vaccine, slightly under on pneumonia, and then we're significantly under on the follow-up in 7 days. What Katie alluded to was that when we showed the results to each of the hospitals in Austin, many of the people who were attending were not like yourselves. They worked with the data, but they did not enter in the data. And they believe that their Get With The Guidelines heart failure data related to the follow-up appointment was not correct. So I encourage those of you on the phone, as you just got a report from your director about your performance, that you take that to the folks out, if there are others who are working with the data or who are working with the follow-up appointment, and confirm that they are having things documented as they should, so that you can put them in to Get With The Guidelines heart failure. So there's some areas I encourage you, don't just take those emails that are sent from your director. Really open them up, look at them, and then if you have questions on specific measures, we'll have time to talk about that here in a moment. But I want to jump ahead pretty quickly and get our best practices on to give us some things that they're working on. And so I'm excited that we'll start with Christy Wild. Christy is a nurse. She is the Quality Resources Manager for Shannon Medical Center, and they've been working on a process improvement for reduced readmissions. So, Christy, if you're on the line, *6, and tell us what you've been working on.
All right. Good morning, everyone. My name is Christy. I am from Shannon Medical Center in San Angelo, Texas. And one of the things that we've been working really hard on is our heart failure readmissions. That was something we identified a little over a year ago, looking at our trends that we were kind of creeping up. We actually had hit about 27.5% on those CMS 65 and older heart failure readmissions, and so we thought, okay, we really need to step in and do something about this. So some of the things that we actually started doing was we actually hired a transitional care nurse. She based her patients off of Boost and LACE criteria. Those were the patients she went and saw while they were still in the hospital. We created a heart failure form that showed them, the red, green, yellow, like, if they're in the red, obviously need to come to the ER. If they're in the green, it listed out the symptoms, just call your primary care provider, those type things. And we felt like that was really helpful. We had our marketing help us create a heart failure patient manual. So, it was for any literacy level, color pictures. It had a weight log in the back, blood pressure log, all of those type things to start kind of really reaching out to these patients. But myself and the transitional care nurse, we started meeting with a couple of the nursing homes here in town. We did discover that on a lot of our heart failure readmissions, they were ones that we were sending to nursing homes that provided SNF care. And so we reached out to them and started actually working with a couple of those local facilities, having regular meetings with them to see if they could help us treat and manage these patients there in the facilities instead of, a lot of times their first reaction was just send them to the ER. We did implement a program in our emergency department using an Iodine Alert. The Iodine Alert would help the ER identify if that patient had just been in the facility as a heart failure admission. So it would trigger on any patient that had been here within the previous 30 days with a heart failure admission, just to give the ER, hey, heads up, this patient, was just here, and that way they would know this was going to be a readmission. And we would do our best on a lot of those patients, and even kind of our low-risk heart failure patients, treat them with maybe give them a dose of IV Lasix, and let's just get them an appointment the next day in cardiology clinic. So lucky for Shannon, we are unique in that we own our clinic and our physicians belong to us. So even our clinic physicians that maybe don't even see patients in the hospital, they're ours, and that really helps. So we use a lot of incentives to drive kind of the care and go the direction that we need to go with our patient care. So now we've got the ER on board. They're helping us with these patients, and instead of, again, their first initial reaction is just put them in the hospital, let the attendings deal with it. So that really helped impact in the ER. This summer, we hired a gerontologist, which was the first time Shannon had ever had a physician that then could start working even with the nursing homes. So that was a big thing for us as well. We also started really pushing transitional care management codes on the clinic. Probably in the last year or two, we have made that a top priority in the clinic setting. So they're seeing those patients within 7 days. And we actually had our cardiologist take it through our med exec committee, and we have it approved now that all heart failure patients are discharged with a heart failure appointment. We got a little bit of kickback, obviously, from some of the attendings, that felt like, hey, I can manage my own patient, I can handle heart failure, those type things. But we did get that approved through our senior leadership that, no, they're not here to take over your patient, they're here to help manage the patient. And so we were able to make sure that every patient that walks out of our door has an appointment within 7 days, and usually that appointment within 7 days is not only with the heart failure clinic, but because of the TCM codes with that primary care provider as well. So kind of with a lot of these things going on, we do look at our readmissions on a monthly basis in our readmission committee. Those readmissions also they kind of go up the chain. They go to Cardiac Care Committee, which is a bi-monthly meeting, QMC, Quality Management Council, which is once a month, and then it even goes up to our board of directors. But some of the things that I look at when I look at the heart failure readmissions, what I break each heart failure readmission down for is I look at their admission date. Did they leave the hospital with that 7-day appointment? Which provider made the appointment? What was the appointment date? I look at where the location of the appointment was, because if it's not within the Shannon organization, if they have a primary care provider outside of our organization, I do call that doctor's office and I verify, did that patient show up for this appointment? I document who their PCP is. I throw in that admission and that discharge Rothman index from that admission, the initial admission. I note if they went home with any type of home health or if they went to a SNF. I note the number of days after discharge that they were readmitted, what the readmission reason and what the readmission reason was. So we break down every single readmission and we look for trends, patterns, that type of thing. One of the trends that we have kind of discovered by looking at this on a monthly basis with these heart failure patients is a lot of them are getting asked on discharge from that readmission, they're going home with hospice. And so that's kind of our next step, is to start looking at how could we intervene. Do they need palliative care or hospice on that index admission? Of course, that's always a hard topic. Nobody wants to have that conversation, but we are really trying to push that into the culture here at Shannon that, if they meet criteria and, they're in stage, usually these patients have a lot of other comorbidities. Let's at least start the conversation. Whether they go home on any type of palliative care or hospice, that's okay. But let's at least start those conversations. So in a nutshell, those are some of the big things that we've done. We have seen our readmissions drop. Second quarter, we were down to 15%. So for Shannon, that's really good, because when we started this project, we were up in that 27% area. So we're pretty proud of the work that we've done, and we will obviously continue on with our projects and with just always strategizing on different ways to affect this heart failure population.
Thank you so much, Christy. We're going to have some time for questions, but I thought we'll go ahead and have our second presenter so we can get all that out there, and then we can have both of them available for questions. So Irene, not positive of how to pronounce your name, Irene, I apologize. Larissa is a nurse, and she's the Director of Clinical Certification for Doctors Hospital at Renaissance. So if you don't mind, star 6, and tell us about the work that you've been doing as you've improved your heart failure quality.
Hi, thank you. So we are, as you had mentioned, a physician-owned hospital. We also are an academic facility, so we work with the University of Texas, Rio Grande Valley. We have some residents here. And I think some of the initiatives that we've been working on is for the 7-day follow-up appointment, and also some of the other quality measures that we look at for the program. We wanted to share just a few things that have helped us. So we see over 600 heart failure patients annually, and we're also certified as a chest pain center, stroke, heart failure, diabetes. We have multiple certifications, so sometimes for the units, there's so many different measures. We find that a challenge. But we do have tremendous administrative support, so we have a dedicated heart failure coordinator. So I think that really helps is, every morning they come in and they look at the census. So what we were able to do is we have a Cerner electronic medical record, and we were able to build the basically off of the ICD-10 codes, a census report that gets emailed out every day to the heart failure coordinator. So she comes in the morning and she'll look to see if that patient is principally here for an admission related to heart failure, and then goes from there as far as, because what we had to do in Cerner is find like a discrete field. So if the physician enters in a diagnosis of heart failure, we're able to capture that patient on our census. And she'll go and she'll kind of look through and make sure that they're meeting all of the measures concurrently. And we also have worked with our data analysts. So definitely we recommend kind of finding somebody in the hospital. It might be your IT or a quality department person who is very kind of Excel savvy, because we found that we can build, I think he called it a form that's based on, what was it called? The Visual Basic. Yeah, so Visual Basic, and he's able to program, like, okay, if they're on our telemetry floor or if they're in our ICU, we have an email that will go out to those units once the heart failure coordinator looks at the measures and updates the spreadsheet, and anything that's falling out is kind of highlighted in red, or if it's something that we need to follow up on, it gets highlighted in yellow. So we're able to track them more concurrently, and then our heart failure coordinator will round 3 times a week to follow up on all of the quality performance measures. So also one of the things that she does is we work on setting up appointments early. So, you know, discharge planning is key. Like, one of the first things is to see, like, what is the discharge plan for that patient. And especially once you start getting closer to, you know, Thursday, Friday, where we're anticipating possibly a weekend discharge, the units round have multidisciplinary rounds every day. So we kind of anticipate what patients might be being discharged on the weekend, and we try to set up those appointments on Friday or even on Thursday and kind of set them out at day 6, so that way, you know, if the patient is still here early next week, we're able to still capture that appointment being set, and it doesn't have to be canceled with the clinics. Some of the challenges that we found were, you know, calling the primary care offices or the cardiology offices and they're full. But probably about 2 years ago, we were able to, you know, really sit down with all of the physicians and just, you know, discuss the importance of how the 7-day follow-up appointment affects readmissions and get them engaged. So, you know, we do have to talk to their office staff, and if we get any, you know, pushback from a physician's office, then, you know, we'll involve our medical director or, you know, just to kind of engage them a little bit more as well. Let's see, what else have we worked on? Another thing is definitely providing education to all the stakeholders. So, like residents, I think we have about 2 to 3 years now that we have residents. So making sure that when they start that they're aware of what the heart failure measures are, because we started seeing some fallouts with some of those physicians as well. And then reinforcing that education. So we try to do lunch and learns with the residents. We also go to staff meetings. We created a badge, what's called like a badge buddy. So it has all of the measures for heart failure on a badge, so that way they could quickly reference it. And then in our facility, we have our own hospitalists, so they're employed by DHR, as well as for our cardiologists, we do have a cardiology group, but we also have private cardiology offices. So that was also one of the challenges, is getting everybody engaged with these measures. And so we do present that data at least quarterly to our cardiology committee, and we talk about any barriers or any trends in the data that we're seeing. We also talk to the hospitalist committee about our data. And also we found that involving the pharmacist on the unit can also be helpful. So usually we have pharmacists that round on our telemetry unit. So one of the challenges we had, you know, several years ago was the evidence-based beta blocker. We saw a lot of metoprolol tartrate being ordered, so that was something that we had to really educate the nurses, the pharmacists, the hospitalists, residents, everybody to get on the same page with the evidence-based beta blockers as well. And, creating reminders in our electronic medical records. So if a patient has an ICD-10 of heart failure, if a physician or somebody puts in that discharge order, it's going to create a pop-up, and it'll just remind them again about all of the measures, making sure that, they're discharging the patient on the appropriate medications and follow-up. And just another thing is also standardizing your order set. So that's a challenge to make sure that the doctors are using the same order set, because a lot of those reminders are built into the order set. So we have like a task that goes out to the nurses to educate daily, and then we had to build a form to capture that documentation. So a lot of different projects that we've worked on. I don't know if anybody has any questions for us.
Remember to come off mute, *6 to ask any questions.
You can ask questions of Christy or Irene.
And you can also send any questions that you think of, or maybe if you want to discuss with your team first, to that swaquality@heart.org, and we can also...
I do have a question. This is Caitlin from Memorial at Colorado Springs.
Great.
Who is you said your heart failure coordinator rounds 3 times per week. Who are they rounding with? Just the team or with the patients?
They usually round by themselves. Usually, they'll touch base with the nurses who have those patients, and they also touch base with the charge nurse. But we found, just to kind of go through each morning and look at the census and kind of grasp what's going on, because a lot of our rounds, the multidisciplinary rounds, take place in the morning, really early. So those rounds usually have the hospitalist or the attending, the nurse, case management, sometimes the pharmacist, could have the social worker sometimes. But for us to really be able to see what was pending for that patient, it takes some time to go through the census list. So usually she does that in the afternoon, and then she'll touch base with the staff and just kind of see if any medications need to be adjusted, or if we need to add any medication. She'll recommend that to the nurse, or she might even call the nurse if it's not one of the days that she's really rounding on. So we really try to work with our charge nurse and the primary nurse.
Do you guys do anything special for patient education as well?
Well, we do have, what's interesting is we did get a grant that we have what's called a CareLink clinic, but they do look at high-risk heart failure readmission patients, and we do have those coordinators who come in and look at specific patient populations. So they do education on, the heart failure zones and educate the patient about medications, but usually it's the primary nurse who is responsible for providing that education and reinforcing the education. And if the heart failure coordinator sees that education hasn't been, if we're not getting an hour of education, or we haven't documented that we've given them the written heart failure instructions, she'll follow up with the nurse. And sometimes they do go in and talk to the patient as well, but we try to leave that with the primary nurses to make sure that, if the heart failure coordinator isn't there, or if they're in meetings, it still is part of their workflow that gets done.
Okay.
And then what the transitional heart failure coordinators do from the CareLink clinic is they come in and they just also reinforce that education. But we do have in Cerner what's called a power forum, so it goes over, diet, medications, everything that is recommended by Target Heart Failure and the Get With the Guidelines program.
Okay. Sounds good.
Good question.
And then we also I think one of the questions that was on the list is PI projects that we didn't really feel worked very well. Was we had like a paper checklist, and we had everything on the paper checklist, and we just found that that they weren't really using it, and so we're kind of looking at other ways. I know one of the ideas was to laminate like ring cards that can go on the computer on wheels, and to do this for all the programs, just to like list all the quality measures, and it just kind of helps serve as a reminder. And then we also talked about having hearts kind of on the patient's door, so that way it can remind everybody on the team, because also we're a heart failure accredited program, so we have to track our daily weights, the NYHA scale. So just having a visual reminder can also help to make sure that everybody follows up on the measures.
I might jump in here that there is, when you talk about the paper chart, we're not going to be able to go through them today, but on the slides you have an introduction to an app. It's a professional app, and you can it actually has forms inside the app, so you can answer those questions. It's like the checklist, except then you can email it, for instance, to your abstractor. So anyway, just a side note, that is one of the resources. Katie will give kind of a high-level review of the remaining slides, but it replaces the paper chart, so that's the paper checklist. So that might be something that might work. We're down to about 3 minutes to go. Katie, you want to give a just quick overview of the slides, the remaining slides that all of us have?
Yes, and once again, if you didn't receive those slides, please contact Larissa or Uri, and we will send those to you. But near the back or near the end of the slides, you'll see some slides regarding target heart failure and the Target Heart Failure app and some other really great resources. Those are just our new partnership with rebranding our Target Heart Failure. There's a Target Heart Failure app that Sheree just mentioned that diminishes the paper trail for heart failure discharge form, heart failure checklist. The LACE calculator is in that. It's a really great tool that you can carry around with you when you're talking to patients. So it's not just something you have to put on paper and then go back to a computer and enter. You can actually do it as you're going. And then there's some great handouts, Spanish and English. I think they're at a 5th grade reading level for patients that you can actually print out from Target Heart Failure, but you do have to register as a Target Heart Failure hospital. It's free. It's easy. The way to get there, the link is in those slides. The way to get to the app is in those slides. So if anyone has any questions about any of that, please let us know, and we will walk you through that. You don't have to work with your IT. You can do it right now as we're talking, and it will work on any tablet or phone. So the other resource that I just wanted to make sure you guys knew about, Scientific Sessions, is being held in Anaheim, California. There's a nursing symposium Monday, November 13th, and then that evening, award-winning hospitals get with the guys. If you want to get with the Guidelines Awards this last year, there will be a reception that night, a recognition banquet. So if you guys are going to Scientific Sessions or have the money to go to Scientific Sessions, please let us know. If you haven't registered, we will help you do that. And then there's a webinar about diabetes and heart failure Tuesday, November 7th. From 1 p.m. to 2 p.m. that we will also get you that information if you're interested in that. It's a great one by Dr. Fonero. So those are a quick overview of the resources. I'm going to kick it back to Sheree real quick to open it for any last-minute questions.
Katie?
Yes.
This is Allison in the Houston area with AHA.
Hi, Allison.
I just had a quick question for our 2 hospitals that shared a best practice. I was just curious what they have put in place with their physicians and other care providers to encourage the prescribing of an aldosterone antagonist at discharge. That seems to be a struggle I hear a lot of hospitals in my area talking about, that they are just not getting physicians really on board with that, and that it's kind of a controversial topic, I guess.
Yeah, so I'll kick that to Christy or Irene if you want to jump on and address that. That would be great.
I think
Or anybody on the line. Yeah.
Yeah, anybody. I'm sorry, I just was referring to them, but anyone can.
That's okay.
I think it's just, having a medical director who's also very engaged and willing to address some of the concerns with the physicians directly. So if we find that a doctor is not prescribing the appropriate, recommended guideline medications, then we'll have our medical director review the case, and then we send them what we call a loop closure letter. So we try to, provide them with education in the letter, or we'll have our medical director also reach out to them, or we follow up with them ourselves as well, depending on who the physician is. And then we try to also discuss, new measures. So like when the ARNI measure came out, discuss it with the cardiology committee as well as the hospitals committee, so that way they hear their peers' concerns, or also that they support, whatever the measures are. But pretty much we've gotten good engagement from our cardiologists and hospitalists here.
Thanks, Irene.
That's great. Well, since and to respect everyone's time, we are at the top of the hour. That was a really great discussion. I know we probably have more, which we can actually carry over to our next heart failure quality exchange if we want to do some more best practices. Or please let us know your director or that SWAquality@heart.org with any questions. We would love to address them, get on the phone with you. But as a reminder, we do have more quality exchange discussions. It's the same exact phone number. There's a stroke one today at noon, a resuscitation one tomorrow at 8 a.m., atrial fibrillation tomorrow at noon, and then Thursday morning there's a coronary artery disease one at 8 a.m., which is probably spills over to more what you all are doing. And then our next quality exchange for this group will be January 30th at 8 a.m. Once again, if there's topics that you want to hear about, things that we aren't addressing that are needs in your hospital, please let us know. This is for you, and we want to do what you guys are needing resources for. So that brings us to the end of this call. If you didn't pre-register, please just email that SWAquality@heart.org. Let us know you attended. We'll make sure you get the slides and resources we talked about. All attendees will receive a resource mailing and a short survey, and that will help us know what you want to hear about next quarter. Thank you so much to our speakers, Irene and Christy. That was great information, and we so appreciate all of you jumping on and sharing with us. Until next time, have a great week. Thank you all.
Thank you.